Eustachian tube dysfunction tests. When is it appropriate to perform Eustachian tube dysfunction testing? How is it performed? And how are the results interpreted? There are several common abnormalities related to Eustachian tube function. Among the most common dysfunctions are obstruction occurring as a result of an anatomic abnormality, local mucosal changes created by otitis media or allergies, patellus eustachian tubes, or palatal myoclonus. The dysfunction can be transitory, as in the case of negative pressure caused by an upper respiratory infection, or in small children as a result of poor veli palatini muscle, that is, ET vectors. It also can be a chronic condition, as in the case of structural changes from radiation, palatal muscle dysfunction from a cleft palate, or from reduced mastoidecil system. Other common overlooked causes for eustachian tube dysfunction include radiation, stroke, and muscular dystrophy. The presence of eustachian tube dysfunction can be determined subjectively through a history of patient symptoms or objectively by means of direct or indirect measures. In the most basic sense, eustachian tube function can be assessed with conventional tympanometry. If the tympanogram demonstrates more than 250 decapascal middle ear pressure, eustachian tube function is presently abnormal. However, this result may not indicate chronic dysfunction. The absence of negative pressure does not necessarily imply normal eustachian tube function. If the tympanogram is normal and if the tympanic membrane is intact, increase the pressure to 400 decapascals, have the patient swallow several times, or perform a Toynbee maneuver, which is holding the nose and swallowing, and redo the tympanogram. If the eustachian tube function is normal, you can see a negative shift in pressure. Then pressure rise to minus 400 decapascals, swallow several times, or perform a Valsalva, and then redo the tympanogram. If the eustachian function is normal, you will see a positive shift in pressure. The total shift in pressure should be at least 15 to 20 decapascals. It is important to note that only about 80% of the adults and a low percentage of children can properly perform these procedures. Now, if there is a tympanic membrane perforation or patent ventilating tube, introduce positive pressure of approximately 400 decapascals. If the eustachian tube opens as a direct result of the pressure, that is, the pressure returns towards 0 decapascals, the eustachian tube is most likely working properly. If the pressure does not equalize, have the patient swallow several times over 20 seconds, and if the pressure still does not equalize, there is eustachian tube dysfunction. Patients reporting autophony, hearing their own breathing, and echo-like vocalizations may have a patellus eustachian tube. Now, this may be caused by significant weight loss, chronic middle ear dysfunction, or hormonal imbalance. Now, to test, set equipment to contralateral reflex decay with a non-auditory stimulus. Instruct patient to A. Breathe quietly through the mouth, force breathing through the nose, and C. Obstruct the nostril contralateral to the probe and force breathing. A patellus eustachian tube would produce compliance changes coinciding with inhalations and exhalations. Eustachian tube measures may be performed prior to repair of tympanic membrane perforation, surgical placement, or removal of ventilating tubes when the patient reports serious difficulty equalizing pressures, or if the patient reports symptoms suggesting a patellus eustachian tube. Remember that while these measures are not infallible, neither is visual inspection. Therefore, eustachian tube testing provides a valuable and objective verification mechanism.